Hello, everybody, and welcome to the Modern Medicine Podcast. How is everybody doing today? I am your host, Dr. Dennis Tian of the Beth Israel Leahy Performance Network, bringing you another episode of the Modern Medicine Podcast. We have an awesome episode planned today. We have a terrific guest, Dr. Wayne Altman, who is a guru of primary care. So if you are someone that is interested in our primary care crisis, what's wrong, what's broken, and a very innovative solution that Dr. Altman and some of his colleagues have come up with to fix it, we're going to get into that. We've got some great stuff in the news, a new way to prevent COVID, some interesting data on mental illness, the long-term benefits of GLP-1s, a paper that just came out on that. So a ton of great stuff there. And then, as always, the Boston Sports Minute, which we are going to move up to concur with our guest because he is also a big Boston sports fan. And then the non-medicine topic of the week. Joining me, as always, the producer, the man himself, Producer Dave. Producer Dave, what is going on, David Yaz?
It's a little warm today in the greater Boston area, but we are in the friendly confines of the Pod 617 studios, air-conditioned. I've got it turned up to 10, Dennis. It doesn't go to 11, unfortunately. But terrific show. Looking forward to it. Awesome.
Thank you, Producer Dave. Yeah, it's still a little toasty in here, Producer Dave.
I'm trying,
I've got a little bead of sweat forming, but we've got the AC going as good as we can, so we're going to plow through. Let's bring in our guest. Let's start with him. Dr. Wayne Altman is a clinical instructor, a friend of mine, actually, from a long time ago, and a clinical instructor of mine because I am a proud alumnus of the Tufts Medical School and recently reconnected with Dr. Altman. Had seen an amazing article that he and some of his colleagues published in the JAMA, Journal of the American Medical Association, about a potential solution to the primary care crisis. So without further ado, our guest, Dr. Wayne Altman.
Great to see you, Dennis.
Awesome to see you, Dr. Altman. How's everything going? It's been a while since we connected.
Everything's going great. We've been working for close to 8 years now on primary care legislation in Massachusetts, and not only do I think it's going to pass this year, but I think it's going to become a national model.
That is really exciting. So we're going to get into all that. I want to tell the audience a little bit about your credentials. You are the president of the Family Practice Group at the Sagoff Center for Family Medicine, president-elect of the Massachusetts Academy of Family Physicians, which is, I think, where you're getting into this advocacy role for policy, and the founder of the Massachusetts Primary Care Alliance for Patients. So you are truly, put it in Star Wars terms, you are a Jedi Master of primary care. I am but a lowly Jedi Knight on the totem pole. So we are truly fortunate to have you here today, and we're going to start by talking a little bit about this primary care crisis that we have in Massachusetts. And I think, Dr. Altman, most Americans would be shocked if they knew where our healthcare system stood compared to those of other developed nations when we look at so many of the big picture metrics like infant mortality rates and chronic disease treatment and adherence to treatment and outcomes around that. We actually don't stack up very good in this country, and I think a lot of people will be shocked. So as someone that's worked in primary care now for a couple decades, tell us about why our primary care system is in crisis, and what are some of the challenges that we're facing in our primary care system?
Well, all you have to do is ask anybody what it's like to try and find a new primary care doctor. Even if you have a primary care doctor, how easy is it to get an appointment with that primary care doctor? The access is abysmal, and it's getting worse by the minute. Right now in Massachusetts, 1/3 of every primary care doc is over 60 years old.
Right.
Okay. So people are on their way to retiring in this age bracket, but people aren't even waiting till 60. People are retiring early. People are reducing their hours. People are leaving the profession. People are shifting to either direct primary care or concierge medicine and reducing their panel size by about 75%. And every time somebody leaves or reduces their hours or reduces their panel size, it leaves the same work for the rest of us, which makes people more frustrated, more burnt out, and creates this vicious cycle. So we're looking to create a virtuous cycle. Now, with that said, access is not the only problem. Affordability is a huge problem. The cost of health insurance and the cost of healthcare is outrageous in Massachusetts and all across the country. We're talking about close to $30,000 for a family to pay for health insurance for a year. Even if you have really high quality employer-based insurance, you're still paying easily $10,000 out of your paycheck for health insurance. So we have primary care and healthcare that's incredibly inaccessible, incredibly expensive, and on top of that, really inconvenient to access, and not nearly producing the good health outcomes that it should be producing.
Absolutely. And I mean, you just hit on all, as someone that's been in the field now for almost 15 years, and you just hit on all the key points and the things that I face, and I know you face every day when we're trying to take care of our patients. And a guy I know both respect, because we're Patriots fans, is Bill Parcells, and he had a famous quote that said, "The best ability is availability," right? And if you look at our primary care system, there are so many problems in our healthcare system that could be solved by a primary care appointment early on in the process, that patients are not able to get in, and these small problems turn into big problems. That small heart failure exacerbation that could easily be solved by just doubling the dose of Lasix, right? Doesn't get seen early on, and the person ends up in the emergency room a week later, spends 9 days in the hospital, and it costs 10 times as much. This is the story of our primary care system right now.
Well, you can never go wrong quoting the big tuna.
That's right.
And a couple of years ago, it was a Tuesday night. I see patients late on Tuesdays, and I got a phone call from my wife about a family member who was in the emergency department nearby. And I was summoned to head straight to the emergency department to help support them. I walked into this emergency department of a major reputable hospital, and I counted 85 people waiting in the waiting room. People in pain, people looking uncomfortable. And there was a part of me, Dennis, I wanted to start doing my own rounds and walking around the waiting room and just helping people and letting them go home. My wife said no. So I didn't do that. But the Health Policy Commission recently did a study looking at what percentage of people going to the emergency department could be treated in a primary care setting. And the answer to that was at least 40%. Yep. At least 2 in 5 people, probably about half of people who are in the emergency department, don't need to be in the emergency department. And imagine the difference in cost between a primary care visit and an emergency medicine visit. And there's an old joke about the emergency department that the fifth vital sign is CAT scan.
Right.
Okay. And this is not a dig on our emergency medicine colleagues. When they see folks, they've never met them before, and they will likely never see them again. And they don't have a relationship with these folks, so they need to be more careful to figure out what's going on. They don't have the benefit of the relationships that we have in a primary care setting.
Yeah. And, and you're 100% right. And, I'm thinking of one patient right now that I've been taking care of for a while, for about 6 months now. And this is a woman that I'm very concerned about her health, right? And she needs a lot of workup. And she's not truly an emergency room visit type patient. But if I try to work her up as an outpatient, then I'm spending 6 months to potentially diagnose a GI bleed, which I think is what she has. By the time she sees the GI specialist or gets in for a scope before she sees the specialist, depending on how we do it, and gets the results and everything. And you get all these, my point is, you get all these soft ED consults because the system is so broken right now that a problem that really should be able to be worked up efficiently and quickly in an outpatient setting, those of us on the front lines, we're throwing up our hands and saying, if I try to work this lady up as an outpatient, it's going to take me a year. So send them to the ED, even though it's debatably an emergency. And I know that they can get admitted and get that workup. And all that just means is more wasted resource, more lost dollars, right? And more or less efficient care.
Well, let's use your patient as an example, Dennis. If you think about gastroenterology as a specialty, we'll just use GI as an example. Many specialists are doing a lot of the work that primary care needs to do or could do because primary care is so overworked and overtaxed, and their bandwidth is so overtaxed that they don't have time to do it. So some of that work is falling on our specialty colleagues. And what ends up happening? They end up having less accessibility and less availability because they're doing some of the work that we could or should be doing. And then we can't get into them. And then what ends up happening is we end up doing some of their work and they end up doing some of our work. And neither of us wants to do each other's work. Right. So if we can increase the primary care bandwidth and capabilities, it allows primary care to do primary care, and then there'll be a trickle down effect for specialty access as well.
Absolutely. And, I mean, I've always maintained that the best value in our health system is primary care. Like, if you look at where we as a system get the most bang for our buck back overall, it's in the preventive stuff that we do in the primary and secondary prevention that is done in a primary care office really pays back the most towards the system as a whole.
Well, in 2021, the National Academies of Sciences, Engineering, and Medicine put together a report on primary care. And in their report, they showed data that showed that primary care is the only aspect of healthcare that when you invest in more primary care in a community, in a region, you actually produce better health, longer life expectancies, fewer health disparities, all at a lower overall cost of healthcare. Primary care is such a value that it delivers more for less.
Absolutely. I mean, we spend and waste so many healthcare dollars on this elaborate and expensive testing, sending people, 84-year-old people with dementia, not to disrespect that, but for like stress echoes, right? When the real bang for the buck is going to be, vaccines and getting people with diabetes on the right meds and getting people with high cholesterol and statin, all that stuff. That's what really pays back. But so many of our dollars are going elsewhere. And I think that's a real injustice and one of the reasons why we struggle at so many of those big picture metrics. So I want to shift gears and talk a little bit about your article in JAMA because it was absolutely terrific. And basically what you and your colleagues proposed was this very innovative and unique idea of treating primary care as a utility. Like we have gas company and we have an electric company, and there's a private aspect of that, but then also a quasi-government regulated aspect of that that's supported by the government. And this sort of hybrid solution is what you're advocating for could be brought to a primary care model. So I'd love for you to tell me and the audience a little about how that would work and what do you think some of the strengths would be of that?
Well, in this 2021 NASEN report, it called for primary care as a public good and to double the amount of investment in primary care in our healthcare system. And this is exactly what we're calling for with this primary care stabilization fund, or as we call it, the primary care common fund. Now, what this does, we're going to get a little wonky for a second here, but what this does is it creates universal primary care, basically free primary care for everybody. Okay, we can get back to how it's paid for, but it's budget neutral. We're not asking for 1 cent from taxpayers for this proposal. So in Massachusetts, as an example, we have about 7 million people. About 4 million of those folks have commercial insurance. About 2 million have Medicaid for poorer folks, and about 1 million folks have Medicare for elderly and disabled. Okay. And so what we're talking about with this fund at the moment is for folks with commercial insurance. Now, there's two kinds of commercial insurance. There's self-funded and fully funded. This is where it gets really wonky. Okay. The self-funded folks, imagine you're a medium or large size company. You're really fretting the fact that providing health insurance for your employees is outrageously expensive. And so, what you're likely to do is provide insurance yourself to your employees, self-insured. Okay. It also is called an employer-based plan or an ERISA plan. Okay. And amazingly, 60% of patients with commercial insurance in Massachusetts are covered under a plan that is self-funded. Okay. So of the 4 million commercial, we're talking about 2.4 million people. But here's the problem. There's a federal law called ERISA, ERISA. This law says that the state government cannot tell self-funded plans what to do. So if we create this brilliant payment model for primary care and we double primary care investment, it only will apply to the 1.6 million people with fully funded insurance. The 2.4 million people will be left out because they're not required to participate, and they will very likely not opt in. Those self-funded insurance plans will likely not opt in. When we create this primary care common fund that collects money from the insurance companies and pays that money directly to primary care practices, it bypasses ERISA and includes all 4 million people.
That's really interesting. So the state would pay the practices directly to care for the patients in their practice.
The simplicity is beautiful. What's interesting is there's a model that's is getting more and more popular called direct primary care.
Yes.
A lot of people have heard of concierge medicine,
yep,
where people leave their traditional primary care practice, ask people to pay them $5,000 to $10,000, still bill their insurance, and give them VIP care, longer appointments, 24/7 access, etc. And that's fine if you can afford it. Okay. Direct primary care is a little bit different. The doctors who leave their traditional practice and go to direct primary care are allergic to insurance companies. They're anaphylactically allergic to insurance. They won't touch it. They won't deal with it. Okay. And they just say to their patients, pay me like $100 a month. Okay. And you have access to me for primary care. Keep your insurance, but you can dial down your insurance to a more catastrophic version because primary care is taken care of. Okay. And when they dial down their insurance, they probably save more than $1,000. So they end up financially ahead in this model. And it's quite brilliant, this concept of direct primary care. The only problem is most people who go to direct primary care, their patient panel size may go from 2,000 to 500, for example. And when we already have an access crisis, that creates some challenges with access when we're reducing panel size. What we're doing in this legislation is that this primary care fund, the common fund, essentially is direct primary care for everyone without having to leave your practice or decrease your panel size. You get to have your cake and eat it too. Who wouldn't want to eat cake if you have it, Dennis?
I love the idea. So you said that it would require no additional taxpayer fund. Do you want to talk a little more about that? This would come from existing funding sources already. We already spend a ton of money on healthcare in this country. I think people should understand 20% or so of our GDP goes towards healthcare in America as a whole. That's one of the highest numbers of any nation, developed nation in the world. And yet our metrics are so poor compared to some other countries that are spending half as much as us. So we're spending a ton of money already on primary care. Tell us about how a model like this does not require additional taxpayer funding.
So the healthcare pie, as you said, it's already big enough. There's enough money in the system already. We don't need to make that pie bigger. In fact, we should make it smaller.
We should.
Is what we should do. And I think most people would agree with that. And so how do we double primary care investment and not spend any extra money? Well, there is a ton of waste in the system. Okay. And different kinds of waste. For example, when insurance is the middleman in primary care, there's maybe 30 or 40 cents for every dollar that goes towards administrative waste.
Right.
And doesn't help any patients. Another form of waste are the half of people in emergency department waiting rooms that don't need to be in the emergency department and people who get hospitalized when that hospitalization could have been prevented. And so those are big ticket items. And we did a simulation with a national consulting firm that showed within 2 to 4 years that investing in primary care, with doubling the investment in primary care, would literally pay for itself within 2 to 4 years. In the meantime, in the first few years, the insurance companies and the large hospital systems will have to make small investments in primary care and make some decisions. Maybe you were going to build a parking lot for the executives in your hospital system. Maybe you were going to build a new orthopedics wing. Well, those things might have to wait. Like everybody else in this world, you have budgetary decisions, and this legislation says that primary care takes priority because it prevents and it delivers better health at a lower cost. So we're going to prioritize that in the budget.
1,000%. And I mean, you hit the nail on the head when you said waste and inefficiency, because that's really what our problem is. Our problem is not a funding problem. And if I was to ask our audience to think about one thing, is the fact that the inevitability that everybody gets sick and everybody needs healthcare at some point in their life. That's inevitable. So how are we going to pay for that inevitability is the question. And right now we do it in the most wasteful and inefficient way. And one of the things I loved about your solution, your proposal, is that it kind of works in the existing framework to a certain extent. It's radical, but not so radical that it's totally changing and reinventing things, because I think that has its own set of problems. I wanted to ask, we hear so much about a single payer system. How does this differ from a single payer system? I think that's an important question, because it is a lot different than a single payer system.
Right. It's a really important question. And I'm going to preface the question by saying, kind of like the idea of a single payer system.
I've seen some of your posts on Facebook, so I know you do.
Right. When I was in medical school in the early 90s at UMass, the original leaders in the movement of a single payer, Steffi Woolhandler and David Himmelstein, presented to us about a single payer. And I listened to their presentation. And I thought, gosh, this makes so much sense. Why is this not happening? And here we are, 35 years later, and we have not made one step forward towards a single payer system. So you may love that idea, you may like it, you may not like it, but I think we all can agree it's not happening. Right. It's not moving. The closest we got was Bernie in the 2016 presidential campaign, made some noise about it and got people excited about it. Okay. But for some reason, he just wasn't able to communicate to people that this would actually save them money. People would just say, well, they're going to have to raise taxes to pay for this. And people were like, well, forget that. And he wasn't able to explain that you might have to pay $5,000 more in taxes, but $20,000 less in healthcare. Turns out that's a net savings for everybody. So any politician you ask, even pretty progressive folks, if I had a dime for every progressive politician that told me, ultimately, it's probably the right thing to do, but it's not politically feasible, I'd have a hell of a lot of dimes, Dennis.
Right.
So I don't think it's happening in the near future. And so what we're proposing is universal primary care. This is basically a single multi-payer, but a single administrator of primary care. The primary care fund, the common fund, is the single administrator, and multiple payers pay into that fund, and then it's delivered directly through a direct primary care mechanism to primary care practices. This is just for the primary care component. At this moment in Massachusetts, we're talking about 5% of healthcare in primary care. The rest of the entire healthcare system, 95%, stays exactly as it is.
Still need insurance.
Still need insurance to cover hospitalizations, car accidents, unexpected cancers, drugs,
anything
studies,
specialist, everything.
Anything outside of primary care, anything specialist, exactly.
You know, this is, to me, and I'll be completely upfront with you, I'm skeptical of a single payer system. I mean, I know it's theoretically great, but its implementation and whether it would work. But this is one of the things that I think me and people that think like me really, I think, like about the solution that you proposed in the JAMA article. Because when I did my MPH, learning about all the different healthcare systems of the world, and there's single payer, which is one side of the extreme, and then there's what we do in this country, which is on the other side of the extreme. There are a lot of middle ground solutions that could, but used by a lot of other countries, by the way, that have much better healthcare outcomes, that spend much less than we do to get those outcomes, that we could think of and use. And this sort of hybrid, kind of quasi-government, quasi-private solution, I think, is something that would work in this country at this time, and I think people would get behind.
Well, what's interesting, Dennis, is that I think that the components of this proposal are very bipartisan. There are a lot of aspects of this proposal that are regular talking points of people on the right side of the aisle. For example, the direct primary care component is specifically mentioned in Project 2025. Republicans have a love for direct primary care, and I think for good reason. I think there are a lot of really good concepts in direct primary care. Secondly, this proposal amplifies state choice. It amplifies patient freedom to go wherever they want. These are all Republican talking points that we can all get around, whether you're Democrat or Republican, independent, doesn't matter. These are all things that we can agree on a bipartisan basis.
110%. I got to ask one more question, then I'm going to let producer Dave chime in, which is, how do you think doctors and primary care doctors and specifically would react to this? And I'm going to tell you why. One of the things you brought up at the start of this conversation was how many of our colleagues are retiring. 100% agree with that, by the way. I can't tell you how many people, doctors I know that could have practiced 10, 20, 30 more years have gotten out. Doctors need to be behind this. And if you're a patient, you don't really care about how much your doctor gets paid, except for the fact that if doctors are retiring and doctors are leaving the profession and you can't get access to a doctor, then you care. So my question is, how will doctors react to this, and how will this affect doctor pay and doctor salaries? Because doctors need to be motivated to stay in the game.
Well, I can tell you, this legislation has 31 endorsements, and including the Massachusetts Medical Society, a group of doctors that is mostly specialists supporting the doubling of investment in primary care, including the 3 primary care medical societies, Massachusetts Academy of Family Physicians, Massachusetts chapter of the American Academy of Pediatrics, and Massachusetts chapter of the American College of Physicians. So the internists, the pediatricians, the family docs, the specialists, all the doctor societies have endorsed this based on support from their constituency. So I think the support is there from the doctors. By the way, Dennis, also the NPs and PAs have endorsed us.
That's great to hear. And I want you to know, for what it's worth, Dr. Altman, the Modern Medicine podcast also endorses you. So you can add that feather to your cap. Producer Dave, what questions do you have for Dr. Altman?
I just have one question, Dr. Altman, and it allows me to brag as a proud parent. My son Griffin in August will be beginning his medical career at the Temple Medical School. And I was wondering if you had any advice for him.
That's amazing. Congratulations.
Thank
it is really hard to get into medical school.
Oh, we found out. We found out. Yeah. It's stunning. Yeah.
That is a big time accomplishment for him to get into medical school. It must be the parenting.
Thank you.
That must be the reason. And what I tell to medical students as they get into medical school and they start going on their journey and eventually have to make a decision about what field that they should go into, they should just really be mindful of what aspect of medicine really makes them excited about doing their work. They shouldn't be focused on the money and what gets paid more, because with artificial intelligence, that's all going to get discombobulated. It's all going to change around. Just go where you love it and where you think you can make a positive difference in the world, and then choose family medicine.
I don't know what he ultimately will choose. When he first expressed an interest in this, he was leaning towards dermatology. Now he claims he's not interested in that anymore. He's been working for almost 2 years at Tufts Medical Center in downtown Boston in the ER as an ER technician. And so he doesn't want to work in the ER, he doesn't think, but hopefully he's seen enough that he'll be able to make an educated decision. But who knows? Thank you for the advice. I will send it along to Griffin.
Nice. Awesome. Well, listen, we want to thank you. This was terrific, and just a terrific idea. I work on the front lines of this system every day, and it's a broken system, and we have to do something because it's not sustainable what we're doing right now, and it's not moral what we're doing right now because we're just failing too many people. So I thank you for having the courage to stand up and propose what I think is a terrific idea, and happy to help in any small way that I can as well. Now, usually when we leave from our guests, we go to In the News, but because we know Dr. Altman is a huge Boston sports fan, as we are, we thought we might change up the order of the podcast a little this week and allow Dr. Altman to participate in what might be the best part of this podcast every month, the Boston Sports Minute. Producer Dave, if you would, kick off the Boston Sports Minute for us.
It's the Garden. It's Teddy Ballgame, Yaz and Poppy in Noma. It's Brady and Larry and number 4 Bobby Orr. It's Fenway Park. It's the Boston Sports Minute. Let's go. The
Boston Sports Minute, and we have a rich and vibrant topic to choose from. The falling apart Red Sox, the Patriots and AJ Brown. But I want to start with Dr. Altman because I know and I remember from medical school that you are a huge Celtics fan. And your arch nemesis, our arch nemesis, New York Knicks, are on the verge, one win away from winning a title. So I have to ask, what are your thoughts about the fact, are you rooting against the Knicks? Are you hating on them? Or are you accepting of this?
Well, I think it would suffice to say that I am sleep deprived because 2 nights ago, I didn't get any sleep after watching that debacle of a choke by the San Antonio Spurs. What the hell is the coach of the Spurs doing with Joe Mazzulla 2 timeouts in his pocket, 3 timeouts in his pocket, and just watching the lead just continue to whittle down? It was unbelievable to me. And then to watch De'Aaron Fox with a 1-point lead and the ball in his hand go up for a layup against a guy bigger than him instead of just dribbling down the baseline and dribbling out some clock and getting fouled. I think Charles Barkley said it best when he said, we just watched the stupidest basketball team in the NBA.
Yeah. I mean, you can't, credit to the Knicks for coming back because they've done it a bunch the last couple of years. But at the same time, you can't give up a 28-point lead without taking some complicity in that, right?
Yeah.
It was gross.
Yeah. I mean, how many times did they just throw the ball to like nobody?
Yeah.
In that final, you felt them panicking. It was hard to watch.
And what about Wembanyama, who has struck me as a guy that's kind of a big moment guy and kind of has ice water in his veins to this point. He's only in his 2nd or 3rd year, and here he was great in the Western Conference Finals, missing 2 free throws that pretty much would have iced the game. I mean, that's just like inexcusable. I don't know if he was feeling the heat or if he was tired or whatever, but that was kind of a choke job too.
Mm-hmm. I didn't love his trash talking in the 2nd quarter, like win first.
Yeah, right.
Didn't hold up well. Did you? I'm sorry, I was just going to say, did you see the shot he blocked? That I think is the only time a human has blocked a shot. That it was 3/4 of the way up the backboard.
Yeah, that was awesome.
It was just incredible. Yeah, he'll be fun to watch for a long time. But yeah, it might not be his time yet. Sorry, Doctor.
He is an alien. But don't forget Game 2 when they had the ball with 9 seconds left in a tie game, and Wemby threw the ball into the back of his teammate.
Yep.
So they have had 2 horrible breakdowns. It should be 3-1 San Antonio right now.
It certainly could be. So the take home here is that Dr. Altman, not a Knicks fan, not rooting for the Knicks, not accepting of this, and hoping the Spurs pull off the miracle comeback. I saw on ESPN Analytics this morning that the series is 84-16. Knicks have an 84% chance to win, which I thought was actually higher than I would have lower than I would have expected. Excuse me. So the Spurs have a 16% chance. Hey, it's not totally remote.
It's one of those. If they win the next game, it does change everything, right?
I agree.
Yeah, because then they just, if they could just steal the game in New York, then they're back in it. But there's a lot of ifs there.
The only thing that would have been worse is if this was the Lakers.
I agree with that. I couldn't.
Well, Dr. Altman, do you not think that this probably doesn't apply to New York? I like to think that any fan who roots for their team for 20 years or more deserves one championship. And our generation of people that we know that are Knicks fans basically have zero, unless you're old enough to remember Willis Reed and company. Do you think they deserve one?
No.
That's awesome. I love the attitude.
Look at the way these Knicks fans are behaving, burning, like beating
I know.
people up who are no, they deserve nothing.
I love it. That's great. I love it. True Celtics fan.
That's right.
All my hardcore Celtics fans,
New York
friends, share the exact same sentiment that you do, by the way. Okay, let's talk very quickly about the Red Sox. He's a Red Sox season ticket holder, too. Producer Dave and I, we have talked a couple times on this podcast about if we're giving up hope on the Red Sox. What I'm here to tell you today, the last two episodes, I said no. I said baseball season doesn't start until the 4th of July. What I'm here to say today is I was wrong. I'm giving up hope. They're horrible. They're not only horrible, they're unlikable, they're poorly built, and I don't see how they can bring Craig Breslow back. Before everyone takes and points the finger at John Henry, remind yourself this team is 11th in Major League Baseball in spending. They should be spending more, but it's not like they don't spend. The money they spent, they did not spend very wisely, and that's just it.
Yeah,
Doctor, what do you think?
Think about the philosophy of John Henry, the ultra analytical philosophy. He brought Craig Breslow here because no one else would take the job.
Right.
Because they didn't want to abide by that philosophy and the way the Red Sox were operating. They gave Craig Breslow the job because he was cheap. They gave Craig Breslow the job because he would abide by this analytical approach. So the head rots, the what is the expression? It rots from the head. The fish rots.
The fish rots from the head down.
Whatever the damn expression is, he needs to sell the team, and we need to come up with some creative ways at the ballpark to deliver that message of sell the damn team.
Well, people have been wearing bags. I mean, you saw that on their head. That was a big thing. A couple guys got kicked out of there for doing that. So people are, I mean, look, I'm not going back to Fenway this year because I'm so frustrated with just the direction of the team, the whole operation. I went to 6-7 games last year. I went to 1 this year. I went to opening day, and that's it because I'm just like, they dropped the ball so bad on this season. And, you know, one thing I will say is if you really do look at it, a lot of the things they did in free agency, as much as I am ripping Craig Breslow, like Sonny Gray has kind of worked out. Suarez has kind of worked out. Contreras has kind of worked out. It's the young talent, okay, that's killing this team. Roman Anthony, Marcelo Mayer, Christian Campbell isn't even up here. The role players they brought in to fill holes. That's what's really destroying this team. Their lineup is so bad. If you want to laugh, go on ChatGPT and ask him for statistics about how bad the Red Sox offense is historically, and you will get like 6 or 7 historical statistics about how bad they are. You're going back to the 1910s, the last time they had an offense this bad. It is unbelievable how boring, unlikable, and bad this team is.
I would agree and say that the lineup is just so listless. There are a couple guys in the starting lineup every time that you wonder whether they should actually be on a major league roster. And guys like I never think Connor Wong is going to hit the ball hard. Never, ever, ever. Here's one question though. We need a better GM. You got Theo Epstein sitting up there.
Totally.
He's in the back room somewhere. I kind of wonder what that's all about. Maybe he wants to get his hands dirty again. That would be nice. Also, I don't know. Go ahead, Doctor.
Producer Dave, something very strange happened last week. Theo Epstein actually spoke up and criticized Craig Breslow and the way the team is being run. That was really odd. And it really makes one wonder, is he positioning himself to return and ride in on his white horse and rescue the Red Sox? We can only hope so. But if he were to do that, he would have to have carte blanche from John Henry to do the right things.
And you got to figure Henry would give it to him, given the history.
They do have a good relationship.
Who knows?
Yeah, it's going to be a long, boring summer until training camp starts for the Patriots. Last thing I'm going to ask you about quickly, Dr. Altman, because I know you're a Pats ticket holder too. AJ Brown, give us your take. Thumbs up, thumbs down. What do you think?
It's all about relationships. He loves Vrabel. He loves Drake May now. He couldn't stand Jalen Hurts and the coach of the Eagles. I think he's going to have an extraordinary season, and everybody's in their right role now, right? Romeo Dobbs is not a number one, but this puts him as a number two where he should be. Okay, Pub Douglas is not a number two. This puts him in a 3 or 4 with Booty if he stays, and with others. They're in good shape. We actually have a really good wide receiver room for the first time in how long?
Long time, maybe since 2007. Really,
yeah.
A wide receiver room this deep. Yeah,
Can't believe Wes Welker dropped that ball. Oh,
well, it's funny because you're talking about the Knicks and everyone's talking about the greatest moments in New York sports history, and I'm like, look, there's nothing that's going to top David Tyree. Nothing. That was a crushing defeat for Patriots fans, but that was the greatest moment in recent New York sports history, at least in the last 20 years.
It's got to be
at that game in Phoenix, and when I'm on my deathbed, I'll be thinking about that moment.
Yeah, it was brutal. It was something else. It really was. That's hysterical. Okay, I think we should let the good doctor go. I'm sure he's got more important things to do than talk about AJ Brown with us. But we want to say thank you so much for the time, Dr. Altman. This was really great. And
well, thank you so much. I just had one last quick thing to add on the legislation, if that's okay.
Go for it.
A message to your tens of thousands of listeners on this podcast. If they are excited about this legislation, as you and I are, that they should please reach out to their state rep and their state senator and let them know that they should be supporting the primary care legislation that is being considered right now in the Massachusetts legislature.
100%, and I will certainly do the same with both my state rep and state senator, because it is critical that we make changes like this. Okay, anything else, Producer Dave, or we're going to let Dr. Altman go?
Thank you very much, Doctor. Fantastic guest. I hope you return.
Absolutely.
Dr. Tien, Producer Dave, a pleasure.
Absolutely. Stay in touch.
Take care. And
we'll catch you next time. I'll catch you at Gillette this fall.
Love it.
All right. Take care, Dr. Altman.
Bye-bye.
In the news.
All right. Well, that was a great interview, Producer Dave, with Dr. Altman.
Fantastic.
Absolutely fantastic. But we are going to move on to In the News. We got a lot of great stuff to talk about, things that are filling up your news feed, things that you are seeing out there, and we got some interesting articles that we're going to go through. So we are going to start with a new COVID pill. COVID pill can prevent you from getting COVID-19 after exposure to disease. So this is a drug that was FDA approved just 2 weeks ago at the end of May. It is called XCOORA, EXCORA, based on clinical trial results published in the New England Journal of Medicine last month. This pill is a preventive modality available to people who are exposed to COVID, particularly those in high-risk circumstances, can prevent COVID. All I can say to this, Producer Dave, where were you 5 years ago, XCOORA? Really? That's when we really needed you.
But what's the difference between this and the vaccine?
So, great question. So, it's the same in principle. The vaccine is just a vaccinated way. The big difference would be you get the vaccine long before if you have or haven't been exposed to COVID. Whereas in this case, this is like someone in my house has COVID, or I just went to dinner with someone with COVID, and you would take a short course of this medication and it will prevent you 70% of the time from getting COVID. And I'm willing to bet, and I think this is mentioned in the paper, in the 30% of the time that it doesn't actually prevent COVID, it lessens the severity of the COVID.
Okay. Well, it would certainly be useful in addition to the vaccine. You don't hear tale of the vaccine so much anymore. How often are we supposed to get that?
The COVID vaccine?
Yeah.
I mean, that's something everyone should discuss with their doctor, because, it really depends on your medical situation at this point. For people that are really super sick, I mean, I would recommend to my patients in that situation probably to still get it every year. Whereas younger, healthier patients probably can go without it, if they feel comfortable with the risk. But it's a conversation you'd want to have with your healthcare provider and make a decision that works for you. I can tell you personally that I think I went 4 years without getting a COVID vaccine, and then I didn't get COVID for a couple of years, so I decided to get it this year because I'm like, you know what, I'm probably losing some of my immunity. I haven't had COVID in a while, so I went and got the shot this year. I don't know if I'll get it this year. I have to think about that as fall comes. I probably won't, but I think for people without medical problems, younger, healthier people, it's a relative. It's a conversation to have with your doc.
For sure.
All right, let's move. Next study. Okay, this is really interesting. Psychedelic trials are effectively open label. this is a study. This is an article from a journal called the Clinical Trial Vanguard, based on a study, review study from published in PubMed, covering 112 randomized clinical trials of psychedelics as psychiatric intervention. So this is a big trend right now, happening right here in Massachusetts, all across the country. People are using psychedelic drugs to treat chronic mental health problems like depression, anxiety. And if you know from our previous conversations about this, I'm super skeptical about this. And this is one of the reasons why. This article describes something called functional unblinding. Have you ever heard of functional unblinding, producer?
No. It sounds psychedelic.
It's total. It is in a sense psychedelic. So
yeah.
It happens with all psychiatric meds as well as a lot of other meds we give to people. And what this basically is if you give someone, you enroll them in a trial, and some of the people are going to end up in the placebo arm. They're going to get a sugar pill. Some of the people are going to end up in the intervention arm. They're going to get the real drug. For certain medications, it's unmistakable, such as psychedelics, who got the real one and who got the placebo one.
You'd think, yeah.
Absolutely. If you know if you're tripping, right?
Yeah, right.
And if the walls start dripping and you see an elf, then you know you got the real thing, right?
Right.
So this effectively unblinds the participants to which arm of the study they are in. And when many of these psychiatric medication studies rely on self-reportive symptoms or on scales that are based on self-reportive symptoms, we have effectively unblinded people to which arm of the trial they are in, thereby potentially introducing bias into our results.
Yeah. Well, if you know that you're getting the placebo, why are you even doing it? Right?
Well,
is that what it means?
The opposite. If
okay.
you know you're getting the intervention drug,
right,
then you may be more likely to report that it helped you.
Oh, I see.
And that is a kind of a placebo thing, right? Where, like all these funny little features we know about placebo that have been studied, like, for example, medications administered by doctors in white coats are more effective than not, right? Mm-hmm. Medications administered intravenously tend to be more effective than pill. Medications administered in a hospital tend to be more effective than outside, even though there's no difference in the medication, right? Placebo is a funny thing. And when we introduce people bias, if we unblind people,
yeah, they get the med, so they're gonna maybe hope in their head that it's doing something. Hey, it's working, even if it isn't.
Exactly right.
Yeah.
And that's one of the real concerns with these trials. It's one of the reasons that I'm very skeptical that these psychedelic drugs actually have efficacy. And this is not an issue unique to psychedelic drugs. This was actually a big issue for selective SSRIs, antidepressants, which we talked about, I think, a long time ago, which is that people in those trials often get real side effects and know that they're in the intervention group versus the placebo group. And that is thought to be a source of bias for antidepressants, and maybe one of the reasons why antidepressant drugs are not as effective as we hope they would be, because there is functional unblinding in the trials. And I think this is happening even stronger and more profoundly in these psychedelic drugs, because the side effects obviously are even more pronounced. See, it's always in the details.
It's in the details.
Always, you got to understand these studies. A study can say anything.
But sure, this is a different subject, but generally speaking, are you open-minded to psychedelics being used for medical purposes?
Am I open-minded to it?
Yeah,
yes, but I'm skeptical because it's always the side effect. I mean, first of all, is it really effective? And second of all, is the side effect worth the positive effects? I mean, that's the core issue of medicine. And I mean, the way these studies are being done and the functional unblinding that I think is happening, I just don't feel like the evidence is there. Really, I'm skeptical. I'm skeptical of the evidence, and we've been wrong before. So,
yeah.
Okay, next topic. This is from CNN. Nearly 1.2 right up the alley what we're talking about. Nearly 1.2 billion people worldwide are living with mental health disorders, and the number has been growing. Nearly 1.2 billion people had mental health disorders in 2023, reflecting a 95.5% increase since 1990. A new study has found the largest increases were in anxiety and depression, which were the most common disorders in 2023. A study was published in the journal The Lancet, terrific medical journal, reveals trends concerning 12 mental disorders differ by age, sex, location, and socio-demographic factors among 204 countries. So basically, what this study is saying is that way, way, way more people have mental health problems in 2023 than did in 1990.
I'm not surprised, are you?
Well, this is. Can I just say what this is about?
Please.
We diagnose these things way more.
Oh, yeah.
We diagnose them. We've created a whole culture.
Yeah.
Around this.
Well, that's probably the answer, and you know better than I. But it it does seem like, and maybe this is anecdotal, but over the last 20 years, and if I had to blame one thing, I'd blame social media.
Yeah.
You know, that social, it's I'm not saying anything revolutionary here. There've been great documentaries on this and how, you know, our phones were looking for that dopamine hit of someone liking our post or something, and we're obsessed with it. And it does not promote mental wellness. It obviously doesn't.
Well, there
right?
have been scientific studies. I think we talked about them on a previous episode of the podcast that have strongly associated social media use with anxiety, depression. So that's probably a factor.
Yeah.
But what I would say is just like 1990, we weren't diagnosing these things enough. They were out there. The culture was we still had a strong undercurrent of like that 1950s, you know, strong silent type culture. A lot of people that didn't want to talk about these things. Well, now the pendulum has swung way too far. So I don't think there was like 5% of the people in 1990, and I don't think it's 95% more in 2023. I mean, the real number is probably somewhere in the middle, but now we've created a culture where it's like everyone says they have a disorder. You could, I think, as a clinician for 13, 14 years now, I think you could slap a DSM-4 mental health diagnosis on pretty much every human being if you really wanted to.
Yeah. Irritability, stress, feeling out of sorts, fatigue. Yeah. Put all those together and you're going to diagnose yourself with something, right?
So to me, this is much about the fact that we diagnose these things in the social, much more in the social and cultural shifts around permissibility around them and the ideas around them being more permissible than it is an actual increase in pathology over the last 33 years. That's my take.
All right, so we're not quite as in dire straits as it may seem. That's good.
Yeah, I don't think so. Okay, next one. Our boy, Secretary Robert F. Kennedy. He's always providing content for us. Thank you, Secretary. Secretary Kennedy announces historic development in nutritional accreditation standards, new medical school pledges. This is from the U.S. Department of Health and Human Services. The U.S. Department of Health and Human Services and the U.S. Department of Education Day hosted 8 of the nation's leading accreditors, assessed medical organizations to announce a historic development to increase nutritional requirements at every level of U.S. medical education. Producer Dave, what do you think? Should doctors know more about nutrition than they do?
Well, I would assume that they already know a fair amount, but as you say with RFK Jr., you know, the broken clock is right twice a day.
Yep.
And so we've mentioned that before. So maybe he's right more. I mean, focusing on nutrition, there's nothing wrong with that at all. I think our country is probably at an all-time low in terms of just walk down the aisle at the supermarket. How many different kind of pork rinds are there? You know, I mean, how many different kind of snack foods, and everything is processed. And so why not? I don't know, but am I missing something? You tell me.
Yeah, I mean, I think doctors know shockingly little about nutrition in my experience, and I think that trickles down to why patients know shockingly little about nutrition. So I know from Tufts Medical School when I went, which is now, almost 20 years ago, we were one of the only medical universities in the country that had a formal nutrition curriculum. And it was like a 2-week course, and that was it. And nowhere else really got much of anything. And so I think this is actually, again, file this under the broken clock being right twice a day with RFK Jr., but this is actually a hugely important thing. It's a great idea because we need doctors to understand nutrition. If you're a type 2 diabetic and your doctor hasn't explained to you the difference between a good carb and a bad carb, if he hasn't talked to you about something called the glycemic load or the glycemic index, which is the scale that measures how much different carbs spike your blood sugar, if you don't have a basic rudimentary understanding of that, then I'm sorry, we're not really treating the patient's illness, whatever medications we prescribe them.
Yeah, I think people assume doctors know everything about nutrition, and you know, it's not necessarily in their makeup. Not every doctor, anyways.
Yeah, 100%. Yeah. And you know, where I learned most of it, besides the Tufts curriculum, was I did an MPH at Harvard, and I took a class called Human Nutrition, which was taught by some of the most brilliant researchers in the country, really, about things like alcohol and cholesterol and carbohydrates and protein. And so that's where I picked up a lot of my knowledge about it. But most doctors don't get that opportunity. So it's really important now that when we have them in medical school, we're teaching them these basic things, because it is going to be a part of pretty much every patient's story.
Yeah, and it must come in handy for you when, you know, you're giving medical advice, and sometimes the advice is as simple as, you know, eat some more fruit. or get some more protein in your diet, or try to cut back on sugars.
Right. Or the diabetic that comes in and says, I'm not eating any apples, doctor, because I don't want my sugar to go up. And it's like, well, no, you're confused about that. That fruit is actually good for you. The right kind of fruits are good for you if you're diabetic, and the wrong kind of fruits and carbs and the juices are terrible for you, and making sure they understand the difference.
What's your favorite kind of apple?
Oh, Honeycrisp.
Yeah.
100%.
Yeah. Delicious never.
I jumped right in on that, didn't I? I didn't have to think.
I'm Honeycrisp or Macintosh.
Yeah.
The delicious apples, I have no use for them. It's the most misnamed product in history.
I'll tell you, I'm a big apple guy, but one thing that I absolutely hate, and we can talk about this one day on the non-medicine topic of the week, in the fall, apple picking. Apple picking is like torture. Who wants to go apple picking?
It's one of those things you do when you've run out of everything else to do in the fall,
It's a beautiful Sunday. There's a football game on. It's like one of the last good weather days of the season.
Yeah.
And you're sitting up there. There's 9 million people. There's bees everywhere. Bees love apples.
Yep.
Okay, there's kids. It's this poop, horse manure. It is a smelly, rotten apples everywhere. Million people. You all want to get a thing of apple thing, and they walk out of there with 2 sacks of apples. And we all know 90% of those are ending up in the barrel.
Right.
You're not even going to use them.
Yeah.
Go to Whole Foods. Go to Roche Brothers.
Even if you make an apple pie, that only kills half the bucket. So.
Yeah. What do you do with all these apples? 3 satchels? Who needs 3 satchels of apples?
Yeah. Johnny Appleseed.
All right. 2 more stories. Both, I think, really interesting, good ones. This one I thought was interesting. New resistance training guidelines for debunk 3 myths for stronger muscles. This American College of Sports Medicine, this is from Medical News Today, by the way. American College of Sports Medicine recently updated its resistance training guidelines for the first time in 17 years. So this was based on scientific study from 137 systematic reviews. And basically what they debunked was 3 myths about strength training. One is that you don't need to train until failure. That's sort of the old gym adage, right? You don't need to have different equipment and variety. Basic simple stuff is more than sufficient for most people, and that beginners don't need different regimens and programs, that beginners and advanced people can do similar regimens. So they emphasize consistency and not overdoing it, and high volume for size.
So specifically, what kind of things are they saying are good? It sounds like simple things like hand weights,
right?
Or what else is
like high reps, low weights? Getting a burn in, but you don't have to go all the way to muscle failure. You don't have to lift these massively heavy weights to be in good shape.
Right. The bands are what do you call those things?
Resistance bands.
Resistance bands.
Those are great.
Those are great, and they're simple. Yeah,
One of the hardest things I think for all middle-aged guys is to make that transition from learning how to exercise like a young guy to learning how to exercise like an old guy, right?
Right.
And it's a tough thing. But look, you don't need to go lift like 300 pounds. It does nothing for you. It's terrible for everything in your body. It puts a ton of strain where you don't want strain, and it doesn't really do that much for you. You could take a resistance band and go like this 20 times 3, and you're going to get better workout, more tone, more muscle volume, and get the same burn with way less stress on everything in your body. And I think that's something that we all have to, that's just way more effective.
Yep. I like it.
You lift weights, producer Dave?
No, haven't lifted weights in years.
Gave up?
Well, I was never a big weight guy anyways, but I mean, I cardio I'll do. When I was really working out well, it was sort of a cross-training kind of thing, like some sprints, a little bit of weights, a whole mix of things, Yeah. So, but how about you?
I do a little bit. I do everything pretty light now for a long time, and I'm a big fan of resistance bands.
Yeah, no, I have those as well, and that I have like an upper back injury that from diving for a softball in like 2001 that keeps coming back.
Damn.
And the bands is something that really helps with that, and you get a little workout as well.
Wow, did you catch the ball at least?
No.
Damn. 25 years later, here you are.
I know, man.
Tough.
If I could go back, I would have tailed off and not dove for it.
I like the resistance bands because if you go on a trip, you can put them in your bag.
Exactly.
You can get a full
easy
body workout.
You can even like you're on the treadmill, grab that resistance band, do a few reps while you're on the treadmill.
Right.
Multitask.
Absolutely. Okay. Next article, last one. Stopping GLP-1 drugs can quickly erase the cardiovascular benefits. Even a brief interruption in a GLP-1 drug administration tied to change in risk of heart attack, stroke, and death. This is a question I get a lot in my office, which is, what happens if I start Ozempic, or if I'm on Ozempic, or if I'm on Mounjaro, I'm on Zepbound, I'm on Wegovy? What happens if I stop it? Do I get the benefits? How long do they last? And this is something that we don't really know the answer to, but we're getting more and more insight. And what we're seeing is that the benefits of these drugs do tend to wash away when you're not on them. And this is really the first, I thought, major study that I could find that really looked at this issue of the heart benefits. Because, one of the great things about these GLP-1 drugs is the heart attack and the stroke benefit, lowering the risk significantly. And what this study is supporting is that, unfortunately, you stop taking these meds and your risk of stroke and heart attack kind of returns right to baseline. So kind of a bummer on that one.
Yeah, it is, especially because, people are really signing up for a long-term deal with these things.
Yeah.
I know a lot of people who are on it and they look great and they feel great, but it's, I hate to say it, it's almost like a deal with the devil. So you got to keep taking this stuff, but
right,
as long as things are going well, I guess we're fine.
Yeah, and by that you mean the insurance company.
Well,
because that's
that nuance.
Most people that take them and tolerate them well, you inject it once a week, there are no side effects, everything's fine, and then all of a sudden your insurance company changes, or you change jobs, or the contract changes, and you had now you're not getting coverage for the GLP-1 you've had for 5 years, and that's what really screws this whole thing up for people, I think 90% of the time. And unfortunately, these medications do tremendous good for so many people, but it's really hard to stay on them because of this insurance issue.
Yeah, we'll continue to follow the story on the Modern Medicine podcast, of course. Hopefully better news comes.
We talk about GLP-1s pretty much they're a major story.
Of course.
Okay, last topic. The non-medicine topic of the week is what we will end with. Let's play the music. Producer Dave.
The doc is off the clock, so it's time for the non-medical topic of the week.
All right. The best part of the show every week, the non-medicine topic of the week. I'm kind of springing this one on you. I should have asked you if you'd seen this before, but I feel like we can kind of make it work either way. First thing I want to talk about, I'm a big Star Wars fan. You've said you're a Star Wars fan in the past. What are your thoughts on the Mandalorian and Grogu movie?
So this will sound odd, but I've only seen the first half of it. My son.
Fire alarm?
No, my son has autism, and so his attention span is skittish, and sometimes I make him stay for the whole film, and then sometimes I'm like, all right, you want to go? Let's go. So liked what I saw. I was a big fan of the TV show.
Yeah.
And it was just a genius little turn. This is just an aside, but were you a fan of Game of Thrones?
Yes.
Okay, and did you watch the Night of the Seven Kingdoms, it was called? It was like a little spin-off show.
I've heard that was really good.
Really
but
good.
I haven't seen it.
And in similar fashion, like the franchise, and I don't know if it was on all Jon Favreau's doing or nothing, but just genius to pair the two together. You got Grogu, the mini Yoda, and Mando, the strong silent type. But anyway, did you enjoy the film?
I thought it was okay.
Yeah.
I completely get how someone with sensory issues might have a hard time with the movie.
Yeah, that wasn't it. It's just his patience. But thank you for saying that.
Okay, because it was overwhelming.
Yeah.
Like I thought that, frankly, it was okay. There was way too many forced digital special effects and not enough story.
Yeah.
And what I don't understand is, if you watch the show at the end of season 2, probably the best moment in Star Wars since the Return of the Jedi, when Luke Skywalker saves Grogu. Yeah. And they took you right to that place where I think so many Star Wars fans wanted to go, which is filling in this timeline between Return of the Jedi and The Force Awakens. Yeah. And then they've pulled back from it on the last few things. The last season of The Mandalorian, 2 seasons, and then this movie. I don't know. Like, I feel like at some point that story has to be told. But that was one of my disappointments with the movie, was that they didn't really get into that whole timeline.
Well, I'm like you. At one of my favorite Star Wars movies was The Force Awakens, because it was like a new movie, but still kind of playing the old hits. Yeah. A lot of Chewie, a lot of Han Solo. And Mando did that to some degree, like you say, when they brought in Luke, when they had Grogu battling the Rancor, that huge animal down in Jabba the Hutt's basement.
Yeah, that was cool.
That was great. So I like the little callbacks. I don't know. I guess you can only bring Luke back so many times, because he was he was digitally enhanced to make him a young Luke, right?
Yeah. But the whole damn Mandalorian movie was digital effects. So I don't think they should back away from making like digital Luke, digital Leia, like digital, and tell the damn story. That's what I want to see.
Yeah.
And they I don't know. I feel like too much of the stuff they've come out with hasn't really done that. Now, they've done some great stuff that has done. Like Andor was terrific, right? Great story. I mean, that was innovative. But, you know, I still think like it's the mythology, it's the story. It's not the big monsters and the crazy digital effects that make Star Wars Star Wars. And I just thought there was a little bit too much of that digital enhanced stuff and not enough of that other stuff.
I'm with you.
In the movie. Yeah.
It is. You're absolutely right. It's about when we think of the original Star Wars, and by original I mean episodes 4 through 6. It's about the characters and the relationships between the characters, good and evil, and it's like a little fairy tale. I mean, and so yes, I think they have gotten away from that. I'd agree.
Absolutely. All right, let's talk a little bit about World Cup. It's World Cup time, right? So we are about to begin this like dreaded 3-week World Cup experience that we've heard so much about. We're in Westwood, which is like 10 miles away from Foxborough here in the Boston suburbs, and Boston Stadium, as they're calling it.
Is that what they're calling?
That you can't say Gillette. It's now banned in Boston. You can't say Massachusetts. You can't say Gillette Stadium. You have to call it Boston Stadium. Is going to host like 8 of these games. My take on this is like, I'm into it. I think this is great. I'm glad we're hosting it. It might be a little bit of an inconvenience. I'm fine with that, and I'm totally out on people making fun of or mocking the World Cup. Like, this is the world's sport. Just because it's not a huge thing in America, that says a lot about us as Americans, right? Like, we should be in on this. This is a great pageantry. It's great competition. It's a lot of fun. The whole world celebrates. We, Americans, should get in on this and celebrate too, even if it's only once every 4 years.
I'm with you. I'm wary because I live in Foxborough and I am worried about the traffic, but I'm kind of excited I want to go down there and kind of take in all the sights and sounds of like people. It is like the world descending upon us, like the world of sports fans, right? And so to see, all the different flags flying basically, and I do think that's cool, and it's the type of thing that people will complain about and then kind of miss the point of, really, because
that's the worst part about living here, is that sort of provincialism. This is such a great international place to live. We have so much going on here, but we have this attitude, this small-minded attitude, like we can't be bothered with this sometimes, and it is our biggest weakness as a region. So like this is a good thing. We should embrace this, even with a little bit of inconvenience. I think you got to get behind this. Yeah. And the Tartan Army, that's what they call the Scottish soccer fans. Have you ever heard that term before?
I have not.
It's a great term, the Tartan Army. I guess a tartan is like an emblem. If you're like a Klansman, all the different clans had tartans.
Okay.
So all the clans that come together to root for the Scottish soccer team, they call them the Tartan Army. I haven't been downtown in a few days, but supposedly Scottish soccer fans have like taken over downtown Boston the last few days. Did you know that?
No, but that's something I was kind of looking forward to. Is like there's a sports bar on Route 1 there. McMorgan's. It's technically in Sharon. It's like a mile down the street from the stadium. So I go there a fair amount, and it's your average sports bar. Families go in there, and I just think it's funny that there's going to be like a family going in there to get their kids, chicken wings and fries, and there are going to be dozens of people in kilts coming in.
Yeah, totally.
Hopefully they'll be friendly.
Well, what they're saying and what I've heard is that there are people with kilts walking everywhere downtown, Back Bay, downtown, Seaport, Harvard Square. Scottish soccer fans, Scottish shirts, kilts everywhere this week.
Yeah, I'm half Irish, so I think I could pull off a kilt. I think I may. Next time we're in the studio,
just
don't be surprised.
Because you can doesn't mean you should.
That's good advice.
Sensible advice from the doc. All right, I think that's all we're gonna do. We had we'll save a few things for next time. It's always good to keep a few things. Anything else you want to hit on before this?
No, a tremendous action-packed show as usual. Absolutely. And stay tuned. The plot thickens with Boston sports. The plot thickens with RFK. There's never a dull moment here.
Absolutely not. I'm looking at myself in the camera right now, and you know what? I'm kind of dressed like Jake Taylor from the movie Major League with the white sport coat, like when the famous scene when him and Charlie Sheen and they go out to dinner together, Wesley Snipes, and they that's a great scene, by the way. But
when excuse me, Charlie Sheen. This better be good because it's hard for me to get it out. Charlie Sheen is dressed in a jacket and no shirt and a tie.
Yep.
And he says, I look like a banker in this
That's
thing.
a great line. And then we take him out back, kick his ass. It's a great line. Great scene. But that's how I'm dressed today. So I had to make that observation. But listen, we want to thank everyone that took the time to listen to this episode of the Modern Medicine Podcast. We hope you enjoyed listening as much as we enjoy doing it. Find us on YouTube. Find us on Facebook, Instagram, Spotify, Apple Podcast. And hit us up. Anything you want us answered for the next episode, let me know. We will catch you next month with another episode. Have an awesome start to summer, everyone. Be healthy, be well, and be safe.